देखो ब्रो जुड़ के क्या हुआ दिक्कत हो रहा है
Thank you, Sukesh.
चल रहा है
Thank you, sir.
But I took bite from the procedure with the first class menu and holding that transfer from the anterior
कैसे भेजते हैं
So you're using this same device, Pass Mini, from Posture Portal, but Sukesh is from the idea portal. So you do you find the trajectory sometimes the glenoid is obstructing your trajectory going to
कैसा आ
the
रहा है
okay, holding from the idea portal and lifting it up. Okay.
कौन आ गया नरेंद्र
Next is going to be
कोई होगा
Dr.
भाई
Srinivasa. It will be about Remdesivir procedure.
Good afternoon. This is a small procedure, so I thought I would add some more slides to it. Just about the Remdesivir. So Hill-Sachs lesion was described in 1890, but Remdesivir procedure was described in 1972. And arthroscopic Remdesivir was started in 2007 and 2008 by Wolf and Purchase.
अब देखना
So
देखो
Hill-Sachs lesion is actually is a posterolateral bony defect in the humeral head because of repeated compression fractures which happen on every episode of dislocation. So as we all know, we have discussed in the morning about the bipolar bone loss. So initially, the Remdesivir, when it was described, arthroscopic Remdesivir initially, it was done in patients whom the Hill-Sachs lesion was engaging on the table. So on the table while operating, they used to do the maneuver to see whether the Hill-Sachs lesion is engaging or not. So whenever the Hill-Sachs lesion was dynamically engaging, so those cases Remdesivir was done. So later on, after the advent of bipolar bone loss concept, then even considering both the glenoid and the Hill-Sachs lesion, the smaller and smaller defects became important. And the on-track lesions and off-track lesions were described by Burkhardt. So on-track and off-track lesions, basically in glenoid bipolar bone loss, there is a humeral head defect and also the glenoid side defect. So the Hill-Sachs interval and the glenoid track are measured. Whenever the glenoid track, as you can see here, the Hill-Sachs lesion is the blue part and the glenoid track on the glenoid part. If the glenoid track is less than the Hill-Sachs lesion, then it is an on-track, it's an off-track lesion where the Hill-Sachs lesion can engage and cause the dislocation episodes. So with the advent of bipolar bone loss, if we can see clearly the last two images, the off-track lesion can be created by in two conditions. Whenever the Hill-Sachs lesion is quite big, it can become an engaging lesion and become an off-track lesion. Also, if there is a small Hill-Sachs but a larger glenoid bone loss, it can again become an engaging lesion. So what is actually Remdesivir procedure? It is actually Remdesivir in French means to fill. So we are actually filling that bone defect on the humeral head using the posterior superior capsule, and also the infraspinatus tendon. So So this is how it looks like when there is a defect in the humeral head, which can engage actually. On the right side, if you can see before the before the Remblissage procedure, the Hill-Sachs lesion is engaging on the anterior glenoid, and it gets levered and causes the dislocation. So once you fill the defect with this tissue, the tissue becomes extra-articular and it doesn't get engaged with the anterior glenoid. So, so that is how it actually helps in preventing the dislocation. So once the tissue is filling here, if you can see on the lower image, previously as it was able to engage on the anterior glenoid and dislocate. Now after the capsule and the insus minutus is filling the defect, it becomes extra-articular and does not cause any dislocation. So once this procedure is done, usually it restores the stability of the joint, shoulder joint to normal levels, and it also reduces significantly the anteroposterior translation of the humeral head, which can cause the dislocation. And also in the abduction and external rotation position, in a case of instability, generally the effects of the humeral head is seen more moving towards the antero-inferior part. But after the Remblissage procedure, it moves more to the posterior-inferior position, and in that way it avoids the dislocation. So standard indication is always an off-track Hill-Sachs lesion. And of course, nowadays we are trying to use it for more smaller lesions with minimal glenoid bone loss, and also for severe glenoid bone loss where usually Latarja and ICBG procedures were done. Now we are using a smaller bone, pre-bone block procedures like scapular spine bone block or distal clavicle bone block, and along with it we are adding Remblissage. So steps involved basically the portal creation. It is just I generally create the posterior portal initially for the diagnostic and do, as Dr. Shukesh has shown us very nicely, to the pancreas elevation and all can be done even before Remblissage, but definitely once you are done with the elevation and all, probably you have to come back to the Hill-Sachs lesion. I generally view it from the anterosuperior portal and work from the posterior portal. I put the anchors and take the bites from the posterior portal itself. And I generally tie the sutures without, I don't view the knot tying and all to the subax space. So, so this is the Hill-Sachs lesion, which you can see, and once we have done the diagnostic round, I go into the superior portal, and once I am in the anterosuperior portal, so this